Hello, everyone. Welcome to AeHIN's the webinar today entitled Health Data Governance Draft Model Law, How to Implement. With us today, there'll be 6 distinguished speakers and 2 reactors. And for your information, Transform Health and AeHIN are supporting the development of a global health data governance regulatory framework that contains draft model, legal and regulatory text, articulating core elements for health data governance regulation, framed around equity and rights-based principles. This will inform the development of a global framework. Transform Health and AeHIN are also engaging governments to build political will and support for this work, including through bilateral advocacy with priority governments. In early 2024, a public consultation on the draft model law on health data governance was conducted in different regions, including one in Asia. So in this webinar tonight, we would like to focus on the following objectives: introduce the draft model law on health data governance to a wider audience, partner and country sharing on their experience with health data governance implementation, invite reactors from legal background, digital health, and others to share their feedback on implementation of model law in different countries. With that, I pass to our Secretariat, Jocelyn, to take us along.
Yeah. Thank you, Dr. Fazila. So in tonight's webinar, our distinguished speakers will share their insights and experiences. We have an exceptional lineup for you today. So the first one will be Ndifanji from Transform Health. She is the policy manager at Transform Health. She supports the development and delivery of the coalition's policy and influencing work. She is a global health advocate, researcher, self-driven and transformative leader with over 8 years of success in various roles. Second, we have Dr. Palitha, Karunapema, and Dr. Pradeep. So Dr. Palitha is the Director Health Information of the Ministry of Health Sri Lanka. He is a public health specialist from Sri Lanka with over 20 years of experience in the field of public health. He was the lead for the development of digital health blueprint for Sri Lanka, which is also a landmark in Sri Lanka digital transformation. And sharing the same presentation is Dr. Pradeep Silva. Is a specialist in health informatics with over a decade of experience in digital health. He's currently the consultant in health informatics, heading the digital health strategy and governance unit at the Ministry of Health Sri Lanka. Following that, we have Dr. Kidong Park, which is the Director of Data Strategy and Innovation Group, WHO Regional Office for the Western Pacific. He assumed the role on 1st May of 2022. Dr. Park has extensive experience in global health, health policy and management, and strategic planning and evaluation. His international career in public health spans from high-level representative roles to technical work on communicable disease control and health system strengthening. And then we have our partners, Jerome from the HELINA. He is a Ugandan legal and healthcare professional with expertise at the intersection of health data governance, digital health, and medical legal consultancy across Africa. He's currently the lead consultant for HELINA, Transform Health, and Africa CDC in testing the model law on HDG in Uganda, Rwanda, and Malawi. We'll hear more from him today about this ongoing project. Last but not least, we have Pak Anies Fuad. He is a public health researcher and academician with strong interest on e-health. He has been involved in various projects, research, and consultancies related to health informatics development and evaluation in Indonesia. He is also our governing committee and among the founders of AeHIN. We welcome all the speakers tonight, and we also have 2 reactors, Mr. Tengis from Mongolia and Judge Thidarat, who will react after the speakers have shared their experiences. And now I would like to share upon some housekeeping rule. So before we start, here are some reminders. So attendees' microphones and webcams are disabled during the speaker's presentation. You may enter questions in the Q&A box or in the chat box anytime during the webinar. For other concerns, please chat with AeHIN Secretariat so we can assist you. We also request everyone to please refrain from using third-party applications, AI bots, or turn them off when attending AeHIN hosted webinars and meetings. We are recording the session and we will share the recording through our YouTube channel when permitted by the speakers. To protect everyone's information, we will dismiss attendees joining via Otter or other similar applications. Thank you for your understanding. We will take a group photo with our speakers at the end of the webinar, so please turn on your camera. Please turn on your camera if you would like to join. And now I'll pass on the mic to our first speaker, Ndifanji from Transform Health.
Thank you very much, Justine. All right. Good afternoon from Malawi. Good evening, everybody. It is a pleasure to join this event hosted by AeHIN. My name is Ndifanji Namacha, and I'm a policy manager from Transform Health. Transform Health is a global coalition of more than 200 organizations that advocate for and support the enabling environment for digital transformation of health systems to deliver universal health coverage. Our work centers around 3 coalition objectives, which are building consensus and political will to strengthen the enabling environment for digital health transformation, strengthening health data governance, and advocating for increased and better coordinated and aligned investment in digital health. Across all aspects of our work, we are committed to promoting the perspectives and leadership of youth, women, and marginalized communities. The digitalization and the use of digital tools has become an integral part of health systems and health system delivery, and are integral to closing the equity gaps and accelerating universal health coverage. Digitalization also has exponentially increased the generation of health data, which is a vital asset and foundation from the 21st century health systems, thus enabling digital transformation and artificial intelligence, advancing research and innovation, improving data-driven decision-making, but also supporting healthcare professionals. However, to achieve the vast possibilities that digitalization offers, health data needs to be effectively and equitably governed, including through robust legislative and regulatory environment, to ensure the right protections are in place, to safeguard data, but also to mitigate the risks of data misuse while also supporting responsible data use for public benefit. It is also important to build public trust in health systems whilst fully harnessing the value of health data as both and individual public good. As discussions advance around the opportunities of digital health and AI, data governance must be central to this. This is why Transform Health and many other partners are calling for a regional and global health data governance framework to be developed and endorsed by governments as a step towards more robust and equitable national legislation and regulation to maximize public value of health data whilst protecting individual rights. We can see from the image in this shown in this slide that there's a growing consensus and wide political and stakeholder support on this issue. During the last World Health Assemblies, several ministries of health have co-hosted and spoke on sessions on health data governance, including Cameroon, India, Indonesia, Maldives, Philippines, Sri Lanka, and the Council of Ministries of Health in Central America. The images that you see are just some of the many reports, strategies, and initiatives recognizing the need for action. Among other global and regional and national initiatives, Transform Health and partners, including AeHIN, have been supporting efforts to improve health data governance, including stewarding the development of equity and rights-based principles, supporting the development of a model law on health data governance, working with communities-based organizations to raise public and political awareness and galvanize action through our My Data, Our Health campaign. This is alongside efforts to encourage governments to support the development and endorsement of a global health data governance framework. The principles and the model law are a starting point and the foundation of a global framework. We believe that the endorsement of a framework by governments through a World Health Assembly resolution and regional mechanisms will help us to build consensus and commitment around global standards for health data governance and essential areas that should be addressed through national legislation. Establishing a global health data governance framework will also help us to establish a level of compatibility in national approaches to foster greater legal coherence across jurisdictions. And it's also important to provide a resource and flexible framework to support governments in establishing national frameworks. Transform Health, AeHIN, and other national, regional, and global partners, including the Africa CDC, the Health Data Collaborative, OECD, HELINA, Recancer, and Young Experts of Health, have been supporting the development of a model law on health data governance to serve as a tool for governments and a step towards the development of a global and regional framework. To support the development of the model law, we have been working with a team of legal experts with oversight of an expert advisory group from the Africa CDC flagship on health data governance. This model law on health data governance has been developed through a consultative process engaging nearly 1,000 stakeholders from across the globe, including several national consultations hosted by Ministry of Health, many of which are across the region. The model law on health data governance has been informed by the equity and rights-based health data governance principles, which have already been endorsed by over 170 organizations at the moment. We look forward to hearing from some of the governments during our discussion today. The draft model law, which you can access through the QR code on the screen, contains elements and guidance and reference legal text to support more effective and equitable health data governance. It provides a blueprint and flexible framework to serve as a resource to assist countries with their efforts to strengthen national laws, frameworks regarding health data governance. I'd like to highlight that the model law is not prescriptive or imposing, but can rather be adapted to suit the legal frameworks of different countries. Different parts of the model law can be inserted into different existing laws within a country or support the development of new laws. It aims to strike a delicate balance between the protection of personal data and community health data and facilitating the use of greater public benefit. The model law aims to facilitate the use of health data as a force for public good, driving improvements in healthcare, research, and public policies. But also the model law aims to address the challenges and opportunities presented by emerging technologies, ensuring that innovation in health data use does not come at the expense of fundamental human rights. The model law also seeks to foster a harmonized approach to health data governance whilst respecting the diverse legal, cultural, society landscapes of different nations. I would also like to highlight finally that the model law assumes the existence of national data protection laws or regulatory frameworks. That's building on the existing frameworks. Where countries do not have a national data and protection framework, it recommends that this is to be prioritized. I'll talk about some of the areas that are covered in the law. We've got the health data court, individual rights, prohibition and re-identification, rights and obligations of health data generators, use of health data for public interest, pandemics and other public health emergencies, emerging technologies, feedback confidentiality, and protection of whistleblowers. Government leadership is critical to move forward a global and regional framework for the governance of health data and more robust national legislation and regulation whilst ensuring diverse stakeholders remaining meaningfully engaged. We encourage governments and other stakeholders to prioritize this at upcoming events in order to advance discussions and turn recent commitments into action. We're encouraging governments to ensure health data governance is on the agenda of the WHO Executive Board meeting in January 2025 and looking towards the World Health Assembly in May 2025. We encourage governments to champion the development of a regional, global, and regulatory framework informed by the model law. We encourage governments to endorse the health data governance principles as a foundation for stronger legislation and regulation. We encourage governments to champion health data governance as part of their regional and national gatherings. And we encourage government to consider how provisions in the model law can be adopted into existing and national legislation to ensure health-specific data is protected. I look forward to the conversations today on how we can foster this forward and champion the development of a regional and global framework informed by the model law. Thank you.
Thank you, Ndifanji. Following up next, we have team from Sri Lanka. Let's welcome Dr. Palitha and Dr. Pradeep for their presentation.
Good evening and good morning to all of you. We are thankful to the AeHIN for inviting for this important webinar. Now, what I'm trying to do is during this short presentation, myself and Dr. Pradeep, we will like to describe about the digital health governance in Sri Lanka, which includes the data governance. So we would like to have a more broader holistic approach for the governance. That's why we take this approach. Over last few years, over last decade, Sri Lanka many health information system digitalized to a great extent. Now, all the public health programs are now having digitalized health information systems, and we have digitalized over 100 hospitals. Then around 2020, 2021, we initiated the development of digital health blueprint, and we have accomplished that in 2023. And it's a remarkable achievement. So we have now solid architectural framework to roll out the digitalization. And again, we based on the Global Digital Health Monitor, our score is for the leadership and governance around in phase 3. Now, about two and a half years back, I'll give a short story, then you will understand. So, we are the focal point for the Ministry of Health for digitalization. So we are facing a lot of issues with relate to the governance. Who should approve the software development, and what is the mechanism for the deployment of different softwares? Who owns the data in different health information systems? Then who will provide the digital infrastructure and connectivity for different hospitals, different public health programs? Then what are the standards, and why we are not interoperable in different EMR? Then what will happen if there's no compliance to the circulars or instructions sent by the ministry? What are the consequences? And what is the mechanism to ensure the data is like that? We got many questions related to governance, which including data governance. Then actually at that time, Jai came to us and asking for whether we can have a convergence workshop. He said, okay, but our focus would be about the overall governance. So basically, AeHIN agreed, and we did a digital health governance workshop in 2023 and have developed a report. Next slide, please. So it was basically a multilateral stakeholder meeting and conducted 3 parallel tracks, and we identify important tools, and basically we categorize IT governance, information governance, and data governance as important areas for our future work. And we have identified the priority areas in each of these areas. Right. Then again, around 2022, we visited Estonia, and also in 2021, they have published e-health governance model in Estonia. So we look at those models and other models available, and then we started drafting our overall governance framework. We use many best examples from region and outside the region. So basically, our expected outcomes of this governance framework is to we need to establish clear roles and responsibilities and governance structure for the Ministry of Health. Then again, responsible optimal utilization of existing resources without duplication. And improve organization performance and compliance, and again align IT investment, because there were a lot of IT investment come into the country, and so governance is really important. Without that, it is very difficult to streamline those things. Then again, establish ability digital health system to gauge risk, mitigate threats, handle changes and contingencies. And MNE is also part of this expected out of digital health governance plan. And basically, our approach was like using this WHO ITU framework, and leadership in governance is basically cut across all areas. So we thought about having this kind of approach in our developing our governance framework. I would like to invite Dr. Pradeep Silva, who is a consultant. And also I would like to thank at this stage, there were many people contribute to this, especially Dr. Kaushalya, who was actually leading this work previously, and she went to the foreign training. And I would like to invite Dr. Pradeep Silva to continue this presentation. Over.
Thank you. Thank you so much, Dr. Palitha. And continuing from where Dr. Palitha has introduced the initial work that we've done on digital health governance, I must reiterate the fact that the 7-pillar framework from WHO is going to be our key bread and butter of implementing digital systems in Sri Lanka, and this is what we followed in terms of implementing different systems. As most of you all know, people would think generally of no services and application and infrastructure to be important in implementing systems, but there are other aspects, especially the standards and interoperability, as well as the workforce legislation and so on, and investments that's going to be there. And all on top of all of that, there should be a certain amount of leadership and governance. That's where we are now. After about just over a decade of implementing digital systems, that we've come to realize that leadership and governance has a very unique and important role to play. So let me explain a little bit in detail of what already Dr. Pals explained a little bit of what the digital health implementations that are already there throughout that has been happening throughout the last decade. So, development and implementing of ICT infrastructure in different various hospitals, as Dr. Palt mentioned, about 90 hospitals, plus another 30 coming up. So it's a large undertaking. And along with that, we've made sure that there is capacity building within the HR capacity and the skill sets that are needed for digital health are being developed, especially specialists in health informatics consultants, as well as the ICT cadre, and so on. There are gaps I will explain later, but that's been happening. And also, we've tried to establish these interoperability layers in the recent past, based on the fact that we have been developing siloed health information systems in different hospitals, and they need to be connected, and patient data needs to be shared. And also, moving on with has been different policy developments, the health information policy, which is cabinet approved in 2017, and then the national year standards and guidelines that can be assisting in the digital health development process. While all that is happening, we had to also look into the security and privacy aspects as the database. Our databases became larger, and the access to health these databases were from different healthcare institutions and by different individuals. All along, we were also very keen on engaging all the stakeholders in terms of curative care sector, the public health sector, which is very large in Sri Lanka, as well as the administrative health administrators who need different information for digital health, health planning, and so on. So innovation was also one of the key things that we came across, and frugal innovations, which are pretty much what is suited for a developing country like Sri Lanka with limited resources was always and has been one of our key points that we wanted to push through. And the information system, most of the information systems and interoperability layers are currently homegrown, and we are supported by the skilled staff that are there. Um, but as things turned out, and as Dr. Palitha correctly explained, that during the last couple of years, we realized that the importance of governance, where all these systems must come into play and be on the same strategic direction that we want to go towards the next 5 to 10 years. So, because some of the healthcare institutions were kind of acting on their own, the healthcare providers were doing making systems on their own and so on, and we had a lot of problems in coordination and the importance of governance, the proper governance mechanism, especially in IT governance as well as data governance was very we realized that it has to be there. So what we did was we adapted this FIGA approach where the leadership and governance make plays a key role, and of course identify what to govern by and who would govern that. So what to govern, of course, is what I explained: all the infrastructure, the information, and the services and the applications that we have already put in place, and also the coming infrastructure which are the interoperability layers, the national data exchange, the national electronic health record, and so on. And also the people and the skills that we have currently in place, and also the people and skill sets that we are going to be employing in the future. So in all that, we've identified different processes, organization structures, and cultures that need to be created in terms of the approach for governance. In doing that, what we wanted to find out in the first place during the last couple of years with the team that is formed there was to identify the different governance mechanisms that are in place already, and also to augment those processes as well as to identify the stakeholder pain points. So there are different stakeholder workshops in terms of identifying stakeholder needs, pain points for governance, the requirements for governance at national level and at the provincial level, regional level, as well as the institutional level. So we are talking about a large health organization where we have about 1,600 healthcare institutions. So it's a large undertaking scattered all around the country. So it's very difficult to capture all the requirements. So what the exercise we've done was taken groups of people and done the exercise of taking the pain points. Then, of course, defining the processes and roles and responsibilities of each level for governance, and establishing the governance structures themselves, and drafting the national governance plan, which would be the plan for the coming years. So under this framework, we've identified different governance structures at national, provincial, and regional level. So mostly the Sri Lankan healthcare sector is mostly public healthcare, state-funded healthcare. In terms of hospitals, in-ward care, it's about nearly 95% is state healthcare. About 5% is only private care sector. And in terms of the outpatient care provision, it's about 50-50 from private sector as well as the government sector. So basically, the structure explains the governance mechanism, which is in parallel to the governance mechanism for healthcare. It is in line with the national level committees. So at the highest level, the National E-Health Steering Committee headed by the Secretary Health, which is also connecting with the external ministries by the Ministry of IT, ICT, the Technical Information Communication Technology Agency, the CERTs, and the other ministries. And then now you have the technical advisory committee at the Director General level, and also the Health Information Bureau, which is the focal point for digital health in Sri Lanka. So at the moment, it is the Health Information Unit, and this Health Information Unit has now been proposed to be entrusted with more responsibilities, equipped with more skilled people, as well as the cadres that are required to establish digital health systems countrywide. So at the provincial level, also it's proposed to have technical advisory committees as well as at the regional level, and going on to the health information management units at the healthcare institution. So this is the proposed structure for the Health Information Bureau. It has different areas: for clinical informatics, public health informatics, applications, and data security, and so on. And then for governance and policy, there's another structure. So also the key point here is that we have also engaged, are proposing to engage engineers or IT section, where we need to engage software engineers and the network engineers, security engineers, and so on. So this is kind of the structure that is proposed for the Health Information Bureau. So something thing or two on data governance. Now, for data governance, what we found out was we have challenges in information sharing, data quality, and the culture of using information. So these kind of challenges are proposed to be overcome through a national data exchange layer, so that national electronic health record, which is a womb-to-tomb health record, will be established. And we have current prototype this through locally developed homegrown software. So we have a plan through funding agencies to already it is in place to develop it into a more production environment, and deploy it countrywide. So this data exchange will serve as the structure to structure data is exchanged. And to support this, we need different laws, regulations, and governance mechanisms, processes to ensure that this data is exchanged. So based on the requirements, we've started with a governance team. We have a technical working group at the Director General level as a technical advisory team, as well as lead at the Health Information Unit, which I head, and also then the relevant policies to be in place, and actually have clear data processes, some of which we have already started doing. And set up controls, and also track progress and monitoring. So also it is very vital that these mechanisms and the idea of governance is put forward to the regional and provincial levels. So we have conducted several workshops at regional level. And the objectives were to advocate people, the high-level people, the administrators, as well as the data information users about the governance structures and the mechanisms. So last but not least, the partner collaboration is very important in terms of having AeHIN and other partners, global partners in this process, especially in terms of having data governance policies and laws, the model law, as well as the national and regional level capacity building. So we are all in supportive of the investments and infrastructure development based on the governance structure mechanisms that we propose. So we have proposed to work together through the organizations, the AeHIN, as well as endorse the model law, and implement those laws and regulations, also in parallel to the current laws and regulations existing in the country. Thank you. So I'll just finish off there. Thank you.
Thank you, Dr. Pradeep and Dr. Palitha, for the presentation. So moving on, we have our third speaker here, Dr. Kidong Park, who will share with us about the HDG and Regional Action Framework on Digital Health. Welcome, Dr. Kidong.
Thank you, Jocelyn. Good evening, sir, from Manila. So, as introduced, my name is Dr. Kidong Park. I'm the Director of the Data Strategy and Innovation at the WHO Regional Office for the Western Pacific. It is an honor for me to speak at the webinar, Health Data Governance Draft Model Law, How to Implement, organized by the Asia eHealth Information Network. On the occasion of the Digital Health Week 2024, I'll talk to you on health data governance and regional action framework on digital health in the Western Pacific. Last month, member states of the WHO Western Pacific region gathered in Manila, Philippines at the 75th session of its regional committee. The regional committee is the WHO's governing body for the Western Pacific, meeting every year to formulate policies, adopt resolutions, and make decisions to improve the health of more than 1.9 billion people living in the region. The regional committee endorsed the regional action framework on digital health in the Western Pacific. It urged member states to use the regional action framework as a guide to develop national strategies, to foster high-level commitments and intersectoral collaboration among government agencies and then other stakeholders, ensure adequate resources are dedicated to build and then enhance digital health solutions. This slide outlines the key message of the regional action framework. It sets the vision of the digital transformation in health sector as the following. Countries harnessing digital transformation for people-centric health and healthcare. And 3 strategic objectives to realize this vision are enhance the digital health governance, people-centric innovative technology, empowered and included actors. It identifies the 5 action domains and provides a list of the recommended actions for countries to consider. 5 action domains are governance, socio-technical infrastructure, financing and economics, digital health solutions, and data. I will explain you each domain why these are important in accelerating digital transformation in health, and what are essential recommendations to consider. Considering the time limitation and the theme of today's webinar, I will focus on governance and data. Before entering into 5 action domains, let me take some moments to explain people-centric health and the guiding principle of the regional action framework. People-centric health catalyzed by digital transformation means that well-functioning information technology, IT infrastructures, focuses on the health needs of the individual and is only effective as the people operating it. A people-centric approach calls for a collaborative, multisectoral, and transdisciplinary approach that account for the broad ecosystem, considering the long-term impact of the action today on future generation, and promote individual and the community rights to sustainable environments. These approaches are guided by 5 principles: equity, open innovation, accountability, pragmatism, sustainability. Equity means including all actors in the digital health ecosystem, especially misrepresented or underrepresented minorities. Open innovation. An environment of the open innovation is co-creation and horizontal partnership among digital health actors. Accountability. Building accountable digital ecosystem requires the ability to measure progress, monitor goals, and then ensure alignments between vision and strategy. Pragmatism. A pragmatic approach is taken to maximize the real-world benefits through multidimensional efforts that center on local need and then participation. Sustainability, building resilient and then sustainable health system requires developing the capacity to respond, adapt, and learn from the stresses and then shocks. Now we are back to action domains. First domain is governance. Digital health governance includes governance structure, coordination and engagement, legislation, and other mechanisms. Governance structures of building a thriving digital health ecosystem requires careful consideration of the institutional arrangements that govern all spheres of the digital health. A national digital health agency is the foremost structure that advances the digital transformation of the health and society. The success of such an agency depends on the adequate funding and legal, administrative, and then functional autonomy. Key to enabling the strategic vision for digital health is the development of the national digital health strategy. Coordination and engagements. Well-functioning digital health system requires the governments to engage with a range of the digital health actors, facilitating individual participation and promoting partnerships, including public-private partnerships. Legislation and then other mechanisms, laws and the regulations are crucial for the effective governance of the digital health system. Health data governance draft model law well fits into this action domain of the regional framework. Second domain is the socio-technical infrastructure. It includes three subdomains: the social infrastructure, technical infrastructure, socio-technical interactions. Social infrastructure refers to digital health literacy and awareness, a digitally transformed health workers, and ICT workforce. Technical infrastructure includes hardware on shelves and individual devices, along with the connecting networks. Socio-technical interaction refers to the interconnection between the human workforce and the technical infrastructure of the digital health. Trust in digital health technology is closely tied to the enabling social infrastructure and mechanism. Next, please. Next is financing and economics. It includes three subdomains: pooling resources, investment and reimbursement, and economic impact. Pooling resourcing for digital health calls for a blended finance model in which government pool resources from several sources. Investment and the reimbursements. Cohesive and the strategic investment into digital health are key to building a sustainable digital health systems. Digital health investment requires diverse reimbursement approaches, including criteria for alternative payment models. Economic impacts. Digital health is a booming, spanning both the public and the private sectors. Industry is an important avenue for employment and then income generation. Digital health also enables the saving across the health systems and broader society by streamlining operations and increasing the efficiency of the healthcare processes. Digital health tools directly reduce costs and contribute to savings for the health systems. Next domain is the digital health solutions. It includes three subdomains: needs-based solutions, quality and then interoperability, and sustainable solutions. Need-based solutions. The choice of the solution should center the nation's, the country's current and future health priorities and urgent gaps. Quality and interoperability. For digital health solutions to be optimized in health systems, they should be interoperable. Interoperability enables a seamless exchange, improved data integration, and the better use of the health data between different systems, applications, and the stakeholders. Sustainable solutions, ensuring the sustainability of the digital health solutions requires user acceptance, universal access, and scalability to be cornerstone of the implementation and rollout of the solutions. Next, and the fifth domain is data. Digital health has brought on significant changes in data capture, processing, analysis, and use. These changes have resulted from the proliferation of the real-time multi-source data from health systems, relevant non-health areas, and then individual wearables, and then remote tools. This evolution demands consideration on multi-sourcing, processing, and analytics, and then uses. Multi-sourcing. Data in digital health is marked by new, increased, and then diverse sources. Traditional health data, such as the electronic health records, are complemented by a wealth of the non-health data. Processing and analytics. While digital health generates more data from diverse sources, it enables newer, faster, and enhanced means to collect this data. Uses refers to enhance the usage of the intelligence generated by digital data analytics gathered from multi-sources. Individuals can actively participate in their health and then care decision-making by harnessing the diverse and the real-time health data available to them. Health workers can optimize their routine work by harnessing health data through digital solutions. Decision makers at various levels of the health facilities and government agencies can make more informed and strategic decisions by optimizing their use of the health data. The regional action framework also provides essential and desirable recommendations along each domain. Today, I'll just share with you essential recommendations highly relevant to the digital health governance draft model law. Under the governance domain, it recommends map, create, or review existing laws, regulations, and/or policies to promote equity and trust and to ensure the safe and appropriate use of the digital technology in health. Establish clear policies, procedures, and/or guidelines for data governance to maintain data quality, integrity, and security. Under the data domain, it recommends designate an entity responsible for data access, security, and quality control. Define roles, responsibility, and requisite competency of the health and public health related ICT workforce with regards to data generation, processing, analysis, and utilization. Ensure compliance with the data governance mechanism for data quality, integrity, security, and confidentiality. I believe that the Regional Action Framework on Digital Health and the Health Data Governance Draft Model laws are well complemented each other in supporting countries' digital transformation journey. I'll stop here. Thank you.
Thank you so much, Dr. Kidong, for your sharing. So follow up next, we have our partner, Jerome from HELINA. He'll be sharing about health data governance in low-income settings, lessons from implementing the model law in Uganda, Malawi, and Rwanda. Welcome, Jerome.
Thank you very much, Jocelyn. As introduced, my name is Jerome Mpaata Owagage, specialize in Health and Data Association, HELINA model law on health data governance across 3 select African countries. And this work involves developing frameworks to manage and protect health data basing on the model law So essentially adapting it to context in these countries. And we are currently, actively doing that. So my submission to you, I don't have any slides, but it's just to reflect on the activities that have been happening with respect to implementing this model law in Uganda, Rwanda, and Malawi, the lessons we've learned and what to do and what not to do. I think what not to do will actually tell us what to do. So I'll be very brief. But the first thing that we have learned is that local context obviously is key. And this law means many different things in many different countries. And here I must highlight that, for example, the concept of rights is different depending on the community that you're interacting with. And that determines the extent to which that community can demand for its rights. All across the board, the three countries, very low income settings. So questions of consent are perceived very differently. The health worker to patient ratio, or rather the patient to health worker ratio, is very low. So for most citizens or regular people in these countries, seeking healthcare, it's very tricky, for instance, to insist on consent when they are being seen by a health worker, because it's a privilege to begin with to be able to see a health worker in some of these countries. There's usually too many patients and very few health workers. So once you get an opportunity to interact with a health worker, questions like, why are you taking my information? Why is this test being required of me? And so on, become very theoretical and not practical in that context. Then the other thing is that we've also realized, well, we might have known already that stakeholder engagement is crucial. But of course, this is dependent on the stakeholder mapping. So we are being very careful to not leave out certain stakeholders. We've especially found that patient groups are a key resource when we are considering these questions. And what we mean, or what I mean by patient groups, is that there are patients, for example, very common in sub-Saharan Africa, are groups that are, on antiretroviral therapy. So those are very organized and have a leadership. And so engaging them, well, ordinarily I would have thought we'll just engage the legal professionals, we'll engage the healthcare workers, we'll engage the legislators, we'll engage, the usual suspects on this. But we've realized that, especially here, patient groups and church leaders are extremely important. So the stakeholder engagement has to be comprehensive. And then we've also learned, of course, that despite these countries all having the same socioeconomic outlook, there are still challenges in harmonizing standards. The Africa CDC is working on a continent-wide effort to ensure that all, and indeed this model law is part of that effort, to ensure that all African countries have similar provisions and outlook in their laws. The other issue is that there's a lot of capacity building and training that is required even for professionals, legal professionals to understand that deserves of more enhanced protection. So that's something we're also realizing. So ordinarily, when one thinks of capacity building, they would think of, people that are, unskilled or untrained. But even for legal professionals, for instance, even for health workers, there is need to build their capacity in understanding health data and why, its protection is a major issue that has implications for public health. But then this also seems to be an area that requires continuous monitoring and evaluation. The landscape changes really fast, both in terms of the subject matter that is being regulated, that's health data, there's too much technology is outpacing regulation, but also outside of the subject matter, you also need to evaluate constantly the laws that we are fashioning to ensure protection of health data. So we need to adopt, more frequent amendment schedules. When implementing the model law, I think there are certain things we have realized that we need to avoid. I have hinted on some of those. Well, the first related to context is we shouldn't ignore local context, and we shouldn't try and implement this law, the model law, without adapting it to a specific culture or legal tradition or even health system or landscape in a country. There's just no one size fits all. And it would be a mistake to assume that, there's just this model law and every country is just going to fall in line. It's obviously risky as well to exclude key stakeholders, like I have mentioned already. The stakeholder mapping needs to be comprehensive, but perhaps more importantly it would be a mistake to focus only on legal frameworks. We have to think beyond the legalese and also think about sociology and think about how practical the implementation of the law is, and also think of soft law alternatives, things like guidelines and regulations, and not just classic enactments. There has to be a lot of public awareness, and this may, resolve some of the misunderstandings about the law's purpose and the benefits it has for ordinary citizens. But like the previous speaker has mentioned, or was it the speaker before him, there is need, we shouldn't ignore technical infrastructure needs. Now, this can be a problem in the general health data protection, but also interoperability. And these have to be factored in. The policy framework surrounding these aspects have to be factored in, and conversations have to be had around them, whether there is appropriate technology for secure data management. Servers, the location of servers has been a critical issue in this implementation journey. Increasingly, we are seeing countries that would desire to have the data processed and stored within their borders. Of course, that also has its own practical challenges and investment challenges and budgetary constraints. And the other thing that I would speak to is maybe planning for continuous evaluation, because this is being implemented in a project cycle, so it will start and end, but the law will not be complete, or the model law will not be complete after adoption. That's, I think, really where the journey actually begins, because there is need for oversight of its long-term effectiveness, and there should be mechanisms for regular assessment and updates to continue adapting the law to the evolving data governance and needs, or indeed the landscape, the regulatory landscape in the countries where it is being implemented. So I think that if all these are put into consideration, there is possibly more. I don't claim to be exhaustive in my analysis, but there's probably more. But I think those are some of the basic things that we have realized as we've tried to implement the model law in these three countries. Now, that's as brief as my sharing has been. This is a journey that's still continuing. We don't have the full picture of it yet, but it's looking good. Countries are eager, are keen to have or to enhance the protection of health data. So there is appetite for this initiative. There are a few concerns from some countries on what this means for their own legislative sovereignty. So the idea that the model law is a set of recommendations and not being imposed on these countries needs to be emphasized, so that countries understand, or stakeholders understand, that ultimately they have the sovereignty and the independence to decide what aspects of the model law they incorporate into their own framework. So I'll just wait. I'm really eager for the Q&A session or the feedback. And I shall still be on the call until that time. So I'm really looking forward. Thank you so much, Jocelyn.
Thank you, Jerome, for sharing. So we'll go to our last speaker of the day. I will invite Pak Anies Fuad to share with us about One Health data governance. The floor is yours.
Okay, thank you, Jocelyn. Good morning, good afternoon, good evening. I'm Anis, member of AeHIN board member and also researcher at the Center for Health Policy Management in Universitas Gadjah Mada, Yogyakarta. Very happy to join this interesting webinar. In this session, I will share a story probably from a different angle, perhaps narrower in scope and also more technical, but hopefully still connected to the topic of health data governance. So the topic that I will discuss is about the implementation of the health data governance in the context to tackle AMR, antimicrobial resistance, using the One Health approach. As you know, antimicrobial resistance is one of the most significant challenges right now, not only in the high-income countries, but also in the low and middle-income countries. And the resistance to antimicrobes is not only occur in the health sectors, but also in the human health sector, but also in the animal and also the environmental, given the widespread use of antimicrobials. So in this context, the approach of One Health is essential, given that it will adopt a multi-stakeholder approach to understand the issue and also to tackle the issues. And fortunately, AeHIN, supported by FINE, currently explore the opportunities to improve the uh, problem on IMR surveillance through focusing on the interoperable data standard using the One Health approach. So in the context of Indonesia right now, we have conducted the landscaping in the human health sector, in the animal health, and also in the environment sector. We also identified the data sources, the software and tools that has been used for data exchange related to the IMR surveillance, and also the use of data. So there are several aspects that related to the health data governance that need also to be considered, not only from the perspective of the technical aspect that we have already explored so far. So we will take a closer look into the antimicrobial resistance in Indonesia. After the landscaping, we identified all the stakeholders involved in the struggle to tackle the AMR. So, for example, we identified in the highest level the role of the coordinating Ministry of the Human Development and also the Cultural Affairs that manage or coordinating three main ministries, which is the Ministry of Health, Ministry of Agriculture, in which the activities of animal health surveillance are there, and also the Ministry of Marine Affairs, and also other ministries, including the National Agency for Innovation and Research. Based on our landscaping, we identified that these ministries have a different level of maturity on using the technologies, different level of maturities on using the standard and terminologies for surveillance, and also uh, with a different level of the detail of the data. So, for example, in the Ministry of Marine Affairs, they do not have a specific data collections from the individual level of the species, but they have the analysis on the research base or the surveillance on the aquacultures, for example. So we have the issues on how to combine data from different sources with a different level of data. So that is why the role of health data governance is important to ensure that there will be data interoperability amongst across sectors, and also to build trust and ensuring the transparencies. Because, for example, on the animal health issues, they concern about if the data related to the antimicrobial resistance that occur in the animal sector, which is also part of the chain of the food to the population, whether it will bring also another sensitivity related to the data. So this is also the issue that in our study, it is not well explored right now, but I think from this webinar, we hope we can improve later the result of this study. So in our study, given that we have a different level of maturity, we focus right now to improve the data um, the data collection and analysis, especially on the human health data, in which we propose to adopt the international standard, for example, that has been proposed by WHO, for example, the ICD-10, and also allowing for the classification of the laboratories. We also adopted the Sunomet City and also the Indonesian adoption of the WHO anatomic, therapeutical, and chemical drug classification. And using the FIRE itself 7, we also try to adopt this data exchange mechanism to be implemented in the human health sector. So our exploration right now was only implemented in the human health sector, but we expect that later on we could also implement this into other sector as well, for example, in the animal and also the environment. We also identify the workflow of data exchange from the local level, from the health facilities into the national level. And I think it is also related to what we have discussed before, related to how to use this data and share into the national level. For example, using the global IMR surveillance system of WHO. We also identify several aspects related to the data quality, the interoperability between system, privacy issues, the timely and also transparency of reporting, and also how to enhance collaboration of data sharing among health facilities and also among sector. So based on our analysis, so we currently propose how to improve uh, the the surveillance of the antimicrobial resistance, especially in the human health data. And what we propose using the AeHIN approach of the mind the gaps, fill the gaps, we identify not specifically using the HDG, but at least using the governance context, what are the problem right now in the architecture level of the IMR surveillance, whether we have the blueprint or the roadmap of the IMR surveillance system. How about the people and program management and also the standard and interoperability? So we are currently not yet discussed into the detail about the health data governance, but from our perspective, it is important for us in Indonesia, given that Indonesia just published the new law on personal data protections, the law number 27/2022. And by this year, it is expected that our country need also to develop the derivative regulation after this law of data protection. So I will close this presentation by going to the last slide. So the lesson learned from our project in Indonesia, actually, we learned that from the perspective of health data governance, there are several issues on the implementing the project on IMR surveillance. From the potential, we hope that this project could enhance the cross-data integration and also to improve the technological maturity, especially in the human health data. But also the challenges, we observe the uneven technological readiness across sectors, especially in the animal and also the environment. And we found also the issue on the public sensitivity related to the food safety data, and also the limited adoption of the standard and interoperability in other sector. So we hope that by learning from other countries, hopefully the next step in Indonesian IMR surveillance is also to adopt how to implement the model law on health data governance to steward the IMR surveillance program in Indonesia. Thank you, Jocelyn.
Thank you, Pak Anis. Thank you all the speakers, and I think now is the time for our reactors. So I would like to call out Mr. Tengis, the Secretary of the State Productivity Committee of Mongolia. Maybe about 2 minutes for you to share if there's any thoughts or comments.
Thanks for Jocelyn for inviting as a rector for this beautiful session. First of all, my impression is the draft law is how carefully tailored and well designed, and including almost all everything principles in this draft law. I would like to introduce you to how Mongolia is working on this kind of regulation to implement our digital health principles. So first of all, we had a Personal Data Protection Act around 3 years ago. Mostly our Data Protection Act comes from the GDPR Act. So we during the processing of the data protection law, we are discussing mostly health sector about how health data is should be managed by after the law is adopted, because the health data is very unique, and sometimes it requires the full consent of the patient or parents of the patients. So we decided that there is one exclusive regulation mentioning that the healthcare staff to exercise their rights and fulfill obligations specified in the law for the protection of the health of the respective person and provision of the healthcare services, because sometimes the patient is unconscious, so we cannot get his or her consent. So healthcare staff is able to collect the patient information. So after that, we amended the health law. We are facing one challenge: how the current and future healthcare systems, health information systems, to exchange each other the patient data. So this kind of challenge we have been solved in the health law, which is the Ministry of Health can make the requirements of the health information system, because in Mongolia lots of health information system and softwares, there is a lots of options, so there is no standardization on the health system. It's different on the technologies and different on the information security. So we regulated the minimum standard, the minimum requirement of the healthcare softwares can be regulated by the Ministry of Health. This is just our small experience.
Thank you for sharing, Mr. Tengis. So followed by this, I'll invite a Judge Thidarat, who is doing her doctorate in law, focusing on digital health technology and legal framework. She's also the judge in Thailand's Court of Justice. So, Judge Thidarat, are you there?
Thank you for having me today. So I appreciate the opportunity to join this webinar this morning. And my take on presentations today is that the good governance for health data is pretty important because it's kind of ensure the health information is managed, protects, and utilized in ways that maximize the benefits. But one of my concerns is that it's a global phenomenon that the traditional regulatory process are actually lagging behind this new technology development, and it can create a lot of constraints and challenges in developing the digital health innovations, and also pressuring people to actually adopt the new standard, especially like the model law. For example, like in Thailand, we don't really have a specific agency looking over digital health per se. So different agency kind of like pull on their effort on doing their own digital health developments, and it's can be overly redundant and very fragmented. So it would be good to put forward the thinking hat that how can each country encourage the regulatory system to catch up with this technological development, or maybe we can develop the law that is adaptable enough to catch up with the new technology developments in different process. Also, from what Jerome mentions about cultural differences is kind of like give me a really big recognitions on how cultural differences can bring a lot of effects on the digital health development, because cultural value kind of strongly influence attitude toward health data privacy and protections, and impact how individuals and community and government approach data handling in healthcare as well. And from what I can see, like the Western perspective on data protections are vastly different than what we see in Asians, while we have a very collectivist idea of thinking. So data sharing might not be a big of the issue compared to like the Western culture. But however, we tend to have like a lower awareness on what data privacy is. So I think that's also something that we need to take into considerations about different cultural differences in different countries that we want to use the model law to implement it in. I think that's all my takes for the presentations today. Thank you.
Thank you so much, Judge Thidarat, for your sharing. So now is our Q&A time. So sorry that we're running a little late. We have 3 minutes now for the floor to ask any questions if you have. Feel free to unmute yourself.
I have a question for Jerome. Jerome said about implementing the model law in 3 countries. Just wanted to check if all these 3 countries already have a data protection law, because I see that the model law has a prerequisite that the countries with data protection, with an existing data protection law is preferred. Just wanted to check if these 3 countries have it and how they are aligning with the overall legislation that is in place. And the second question is, if there is a data protection law, how if it is a legal mandate, if it legislatively passed through the parliament or the senate of that country, how is this model being introduced again, or what is the process that they're following?
I have to mention that data protection has not received legislative attention on the continent of Africa generally until at least 2019. So the earliest versions of data protection laws are 2019 pieces of legislation. But also, like the colleague from Mongolia, I think it was, mentioned, most of them are modeled around the general data protection regulation of the European Union. And so, yes, you raise an interesting question, a very practical one, on how these countries then are adopting versions of the model laws. So there's fundamentally three ways that we are inviting countries to use the model law. The first way is to enact afresh, in other words, to take the model law or this text through the legislative process, through the parliament or senate or whatever legislative body there is, and then push for it to be enacted. And this way of doing things has been not very popular with countries for reasons that I spoke to earlier, for reasons of sovereignty, for reasons of the length of the legislative process. But I think we've been building a case to them that health data, yes, you have a general data protection law, but health data, what we are trying to say is that health data should not be treated like regular general data. So the laws that are designed too broadly to protect general data are out of step with the requirements for health data protection. So that's one way. The second way is because most of these data protection regulations have provisions that give the minister power to make operative regulations. And so that's another way in which the provisions of the model or countries are considering adopting provisions of the model law. So in this case, the law would essentially be put in form of a regulation emanating from the principal data protection law. So that's the second way. The third way, and that second way is what the Republic of Rwanda, for instance, is considering pursuing. Now, the third way is for most of these African countries that we are implementing the model law in, for most of them, there is a standalone Data Protection Act or instrument, but then you will find that the Ministry of Health or the government department that is responsible for health is also struggling to formulate guidelines for artificial intelligence, for all these technologies that are in the health sector, etc. So in Uganda, for example, the feedback that we are getting from the Ministry of Health is that this comes at a time when we are struggling with this issue. So rather than wait for legislation, which again can be a long process, we would rather take the entire text of the model law and use it as our guideline. So it's not, it doesn't have the force of a legislative instrument, but it's pretty much what is guiding. So it's sort of like a policy document that is guiding how health data is handled within the sector. But I also have to note, perhaps I didn't mention this in my principal presentation, but for most of these countries, and this might be unlike Asia or most of the West, but for most of these countries, the biggest supplier of health services is the government. Once you have, the main ministry that is sort of offering these services and you have their buy-in on the model law, then it becomes easier. In the Western world, you might find that it's mostly the private players that are dominant in the health sector. I hope that answers your question. Thank you.
Yes, thank you.
Thank you for the questions. We are exceeded the time, so I request that, maybe I think it's time that we might have to wrap up. Thanks everyone for joining, starting from Ndifanji from our partner Transform Health, then Dr. Kidong Park from the WHO Office for Western Pacific, then Dr. Palitha from Ministry of Health Sri Lanka, and then Dr. Pradeep, and then Jerome from our peer network HELINA, and then also the Reactors and our working council members, as well as our board member Anis, who has also shared a new perspective related to One Health, and then the two Reactors, and then all of you who have joined. Thank you very much. Jocelyn, over to you.
Yeah, thank you so much, Sejai, for helping us to close. So if you have any further questions, feel free to just drop in the chat. We will try to get the speakers to answer to you via emails. And before we end, can everyone open on your cameras if you're okay to take a group photo together? Yeah, we really appreciate that. All right, thank you everyone. Sorry for the delay for 5 minutes.
Okay, good night.
Bye-bye.
Thank you.
Thank
Bye.
you.
Thank
Thank you.
you. Bye.
Thank you. Bye.